President and Chief Executive Officer of Hartford Healthcare. Today, we are very pleased to be speaking about some outstanding work that we're doing with MIT and specifically Professor Dimitris Bertsimas. The relationship between Hartford Healthcare and MIT began in our Center for Innovation a number of years ago, and we have enjoyed a very close relationship with MIT. Together, we've used machine learning, predictive analytics, and a whole series of joint projects and efforts together to take some of the conceptualization of the work that's being done at MIT in their laboratories and in their classrooms, in actualizing it and testing it in the clinical environment. And we've enjoyed an outstanding relationship. When this crisis hit, we were extraordinarily pleased with the generosity and the support of MIT, and specifically Professor Dimitris Bertsimas. We pivoted that relationship, and we took the resources at MIT and we pointed them towards our efforts here on the front line at Hartford Healthcare. And Professor Dimitris Bertsimas has put together a team of 20 PhDs who are working really from throughout the world under MIT and his specific direction to use the data of our experience at Hartford Healthcare and the approaches we're taking in the state of Connecticut and at Hartford Healthcare, and using those resources as we go forward to really create potential opportunities to improve the response around these efforts throughout the world, but to leverage the opportunity to pilot those capabilities here. So we're very grateful. Professor Dimitris Bertsimas is a world-renowned expert, and the capabilities specifically in analytics and decision support at MIT are truly the finest anywhere in the world. So the unique opportunity to partner and to work with this level of expertise and to build on the work through our Center for Innovation by making available all of our data, all of our team, all of our resources, and channeling them to focus on how we can use decision support and data to make better real-time decisions on how we allocate people, how we allocate equipment, and how we make decisions on where and how we treat people really could be the difference on how we save lives and how we care for more people under very distressful situations. The work with MIT has also been essential, and you'll learn more about it in a moment from Professor Dimitris Bertsimas around how we use these efforts to make decisions around our modeling, on how we buy and secure and manage our supplies around personal protective equipment, how we stand up our physical resources, and ultimately how we staff our facilities. So the use of this data, the use of predictive analytics, the way we're leveraging machine learning, this is what we've created in our Center for Innovation for years in partnership with MIT, and now we're accelerating its use during this crisis to make an extraordinary difference. And lastly, I'd like to recognize the Hartford Healthcare strategy team and our own analytics team, who have enormous capabilities and have been working truly around the clock in partnership with MIT, because it takes a village to do this work. And we had to make our information available. We had to have great agility in terms of how we're able to respond to these efforts. And our hope, our ambition, and what I expect you'll see today is what we're unveiling and what we're discussing in terms of what we're using on the front line. This will be available ultimately across the country and around the world. And much of that work originated here. And we just are so appreciative of this opportunity to work with MIT. It's been an outstanding partnership over many years. And perhaps the greatest dividends are being paid right in this very moment. So with no further ado, let me introduce through an uplink Dr. Dimitris Bertsimas, who's also a dean at MIT, and is an exceptional academician and amongst the world's greatest leaders in this space. But I will describe him as even a better human being, and to see the way that he has put himself forward and used their really unprecedented levels of capabilities to try to do something that really has application around the world. It's been an absolute pleasure to be their partner and to see their generosity and how they're supporting us in this effort. Thank you, and please, Dr. Bertsimas.
Thank you very much, Jeff. It has been a privilege to work with Hartford Healthcare for many years. This work that I'm about to tell you related to Hartford Healthcare, but a bit more generally as well, has started about mid-March specifically with a group of my students. These are exceptional young people with a lot of commitment, and we have created a website that you can take a look more globally. It's called COVID-analytics.io, COVID-analytics, one word, .io. Let me comment a bit about what we have been doing related to Hartford Healthcare. One question that the team has asked us is to try to build a model for predicting the upcoming surge at the time in early mid-March. If you go to the website I mentioned, covidanalytics.io, you will see the predictions we have for every state in the country and also nationally. And from the very beginning, our prediction has been that the number of deaths in the United States will be of the order of 65 to 70,000. Other models have also come closer to our estimates. In addition, we are working and we are about to release today a personalized calculator that this is at the individual level. When a person arrives at the hospital, what is the likelihood that it will need an ICU, what is the likelihood of mortality, and also prescriptively what could be the best strategy for such a patient, how to allocate ICUs in an area of limited resources to optimize, to minimize mortality in the system. This is utilizing data from Hartford Healthcare as well as data from Italian hospitals for which we have longer history, given that the disease originated, it was much earlier there. Other efforts also include reallocating resources among the Hartford hospital system. This is ongoing work. In the case, I hope we never use it, but in case we need to use it, we have also built models on how to reallocate particularly ventilators among the hospitals of the system. In our website, we also have a model at the national level of how to reallocate ventilators among states and the federal government, how to prioritize, because our estimate is that overall the country has enough ventilators, but specific states at specific times might not. So a more intelligent reallocation might actually save lives. I will stop there, but to reiterate the commitment and the quality of my collaboration with Hartford Healthcare, it has been a privilege to work with people that value human life and are extraordinarily committed and people. And mention that we are at the disposal of Hartford Healthcare system as well as nationally to do the best we can to address this significant crisis that we collectively all face. Thank you.
Introduce yourself.
Hi, I'm Dr. Barry Stein, Chief Clinical Innovation Officer at Hartford Healthcare. Dimitri, thank you very, very much. This is innovation that saves lives. This is innovation that helps prepare our community, our state, and our nation by using advanced analytics and machine learning. This is innovation that's happening right here at Hartford Healthcare in partnership with MIT's Professor Bertsimas, the Bruce Springsteen of analytics. This is innovation that is fueled by years of collaboration and friendship between Dimitris and Hartford Healthcare, with a deep mutual commitment to impact the world so that people can live their healthiest lives. Thank you very much, Dimitris, for your partnership and helping us and our nation during this unprecedented time.
Good morning, everybody. My name is Ajay Kumar. I'm Chief Clinical Officer for Hartford Healthcare. We have enjoyed a tremendous relationship with MIT and working with Professor over several, actually more than a year now, or almost 2 years now. And we've worked in different type of optimization models and capacity planning and surge planning, predictive modeling, especially in the length of stay and many other areas. And I think one thing I'll tell you that working with Professor and MIT has given a really edge to Hartford Healthcare is how we operate, how we work, how we load level across the system, how we optimize entire system as we plan our operation. Now, I'm not supposed to say anything wrong at this time because Professor is going to grade me afterwards because I have been his student and I've graduated from his program, so I'm going to be very careful. But I do want to share that the predictive modeling, which has been proposed by and worked with the Professor's model and our strategy team and Dr. Stein and other members, has been really close to our what we're seeing in the country at the moment nationally. And always there is unknown variables which we cannot control, which can change the direction quite easily. But these have been very consistent. And I think most of you are wondering how that relates to the Hartford Healthcare. So just to talk a little bit about that what we are looking into are capacity planning for the bed amount, number of beds required. So we're looking at the number of ICU requirement. We're looking into the ventilator capacity. And these variables are based on a true science, the clinical science, which is a demographic change based on the epidemiology of the state, and also the clinically what we're seeing based on the studies. So when Professor talked about that our models are based on clinical science, it's talking about the models based on data coming out from South Korea, data coming out from Japan, England, Italy, and coming out from different parts of the United States. So we're able to predict as close as we can based on the behaviors and the social distancing and other things we're seeing in the state of Connecticut. Now the model is actually going to mature over the time. We're going to have a lot more learnings based on the comorbidities and other details as well. The important aspect of the model to understand, these models are not static models. They change and they evolve over time. And these kind of interesting and deep analytical models are going to be the future of clinical science as we go forward. This pandemic, what we're facing, we're going to face more challenges over the time. So this foundational work our team has been able to do in really short time working with Professor, it creates a fantastic foundational model. So with that said, I'm going to go over some of the details about the Hartford Healthcare, how our patients are doing in in our system, and we'll open for more questions. I know everybody's curious to know the numbers every single day, so I'll start with that. We have 324 COVID positive patients across the state of our system. We also have 141 people who are under investigation, waiting for test results to come back. We have a total of 465. We're seeing it's just about 8 to 12%, depending on which day you look into, increase our numbers across in Hartford Healthcare. And I think this is going to continue to evolve over several days till we hit the peak whenever, as we talked about, in the end of April and early May. With that said, I'm going to pause here for Mr. Flaks to make a few comments, and after that, I'm happy to take any questions and answers.
Let's do questions.
Do questions first? I've been ordered to do the questions first. Thank you.
For Professor.
And Professor as well.
This is Alex Futterman from the Hartford Current. I have a question about the model. So how does the model take into account different social distancing guidelines in different states and whether people are following them and whether they might be lifted or extended at various times?
We do it in the following way. There are two key parameters. It's the infection rate, which we use averages, but there is also a parameter, which is in a sense the social impact, the social distancing impact. It uses a particular parameter. What we do is that on a daily basis, we adjust, we know what happened in the past, and we find the parameter that best explains the data so far, and we use this parameter moving forward. So as a result, because this is not a parameter directly observable, it's only observable by what has happened in the past, and we select these parameters in such a way that we match the prior data, and as a result, and we have seen that our models are very consistent in that way. In other words, as days pass, the estimation of these parameters does not change a lot.
And so it looks like online the model only goes through June 14th. Does that mean that you expect the outbreak to be pretty much done by then, or is that just as far as you're comfortable projecting?
The latter. In other words, we are also working to extend further than that. To be honest, during this period, we are reasonably confident that the social distancing measures will be in place and will continue. After that, since we don't know the national policy on the matter, it might be that society opens up. It would be very dangerous, in my opinion, to make predictions beyond that when we do not know what kind of environment we will be in terms of social distancing and testing.
And then I have one more question. So in Connecticut, it looks like it projects, sorry to be a little granular here, but for April 9th, it says about 1,000 active hospitalizations in Connecticut, but the state numbers were 1,400. I'm just wondering how that discrepancy comes to be, what that means.
Yeah, I mean, I haven't checked. The model is updated, will be updated again tomorrow with new data. One should not view this as these are aggregate models. You know, they are not appropriate to be seen what will happen exactly today. But the trend of the model and how it could go, this is what it should be seen. The Hartford Hospital model is more detailed than the national model because we have far more data from Hartford Hospital. As a result, our estimates, and we have a separate model for Hartford Hospital because given we have far more analysis of the data, it's much more granular in that way. But for the national model, we can only utilize it for trend setting as opposed to exact detailed numbers.
That makes sense. Thank you.
Of course.
Dr. Bridget Ruthven from the Republican American, could you be a little bit more blunt about the impact of social distancing policies? We have a number now predicted that is a little bit more than a bad flu season, and for those naysayers and detractors who say, see, it's not really that much different. What is the importance of that, and where would we be without that?
I mean, I would like to, I have two answers on that. I would like to compare California and New York. In California, California has about double the population of New York, 40 million versus 20 million. Yet, in California, we started social distancing a week before New York. If you look at deaths and people infected, it's 10 times difference between the two states. In California is in a far better state, but certain environment than New York. Social distancing is material. In our models, because of the exponential growth of the disease, a week earlier or later makes a material difference in infections and deaths. So you have to be blunt. I believe that social distancing, especially at this time of the disease, is critical to maintain it. To be honest, we don't have, given that our testing is not so widespread, and therefore we don't know who to guarantee exactly. I think this is the best method we have at the moment.
Brian Bitlake with Fox 61. When I go back to our station and relay this message to our viewers, what does this model tell us? Do we see a light at the end of the tunnel at this point? What is this model really showing us here in Connecticut?
I would say, assuming we continue these measures, I believe we have announced until the end of April, potentially even a bit after that, even in the month of May. We definitely expect that the disease will decrease substantially. You see the curve there. By around mid-June, we expect a significant decrease. What will happen after that? It depends how society opens up. and it also very much depends on the amount of testing. Other countries that have been successful in opening their society after that have significant amount of testing. Therefore, the way testing works is the following: is that you find people that are reasonably quickly before they enter society. You social distance those, and then you let society work. So whether it's in addition, there are many other efforts regarding vaccines and therapeutics. We hope with all these efforts that is happening in the world, we will have some good results. This is not a trivial problem. I mean, we still don't have a vaccine for the common cold. But I do believe that with appropriate measures, society will come back, and our lives might not be exactly the same normal. Will come to normal, but we have to be patient with the social distancing measures.
And one more question. Does the model take into account asymptomatic people as well?
Yes, it is a very sophisticated model in this way. It says that it's a progression of disease model. It has various components. It has the susceptible population, the exposed population, but not yet contagious, the infected population, then the asymptomatic patients, and each of them have different ways. Our assumption in the model that a patient for 2 days might be asymptomatic and does not know that he has a disease. That's a parameter that the model utilizes, and it's of course critical. I mean, if people are asymptomatic, are in society, and do not know about it, that's fairly dangerous on exposing the disease. It has all the components that are relevant in this epidemiological model that we have built, for which, in addition to the existing models, we have added, we have utilized data from many countries in the world. If you look at the website, we have utilized data from 130 studies from China, from Italy, from Spain, and other places in the United States to find the appropriate parameters to populate this model. And we are reasonably confident about the values we utilize.
And earlier you were talking about a little bit about the mortality rate. When we heard those numbers, for me it was a bit alarming, but in the grand scheme of things, is it as bad as we think it is, or will it, I guess, even out as time goes on?
Yeah, let me put things in perspective. I mean, in the entire Vietnam War, we lost about 50,000 people. So at the environment we're talking about 65, 70,000 people lost, more than the entire war, one of the major wars that the United States has fought. Just to put things in perspective, and these are people that we did not need to lose. I mean, we're at war with an unknown enemy. The other aspect is if we leave the disease without control, in other words, open the society prematurely, without testing and without appropriate measures, we might get a significant disaster in our hands, far more, an order of magnitude higher than what we are seeing today. I do believe it's critically important, and I gave you the example of New York and California, where it can make a material difference in people dying. I mean, I do think it is one of the most serious threats that the United States and the world has faced since World War II, if we are not careful.
Doctor, could you comment, please, on what you think about the possibility of a second wave or third wave this fall?
Yes, this is a very real risk, in my opinion. And if you look at the pandemic in 1918, there were three, the Spanish flu, so-called. There were 3 waves. The first wave started about the same time as this one, in April of 1918. Most lives were lost in the second wave. And there were also some lives lost in the third wave. I would say absent, therapeutics or vaccines, we should be particularly careful on how to open society, because if the second wave comes, all of our efforts, all this financial devastation we have had with the economy and so forth, will come again. And I would say it's critical to do it wisely, and I cannot overemphasize, absent vaccines and therapeutics, the ability to test at much larger scale than we are today, much larger scale. And our model suggests that. I've done experiments where we can increase the level of testing, let's say twice, 3 times, 4 times what we have today, and finding people to isolate. This makes a material difference in outcome. Factors of 10, in other words.
Is there a possibility that we could have a test that checks for antibodies, such as those people who have been infected, or is it also realistic to test everyone?
The answer on the antibodies, it's not. I think it's feasible to do. We have already technologies that look into that. There are studies. I know companies around MIT, and my colleagues at MIT have developed these technologies. So we can see what happened and who has developed antibodies and therefore can enter society assuming immunity on the disease. And you also asked me a second question. Can you remind me?
Is it realistic, Doctor, to forward the idea that maybe everybody should be tested?
Yeah, I believe this is, in fact, if you look at the countries that have been successful, South Korea and Singapore come to mind, the level of testing is significantly higher than in the United States. I mean, clearly, the nation's testing capability has been increasing at a rapid pace. Obviously, we are going to improve. But to me, when we open society, I believe we will not be successful without testing, because we will not know who to guarantee, who is asymptomatic. And it's not that people would be with good intentions. I mean, they might be asymptomatic. They don't know they have the disease. They will start infecting others without knowing. If we isolate those people, clearly there's a significant benefit to society. I do believe we should increase our testing capability orders of magnitude that we are today.
Thank you. And one more question. How soon might we see a vaccine?
This is a difficult topic on which I'm not an expert. I know that many of my colleagues at MIT and elsewhere are working very hard. I do believe we'll succeed in this. I believe the probability is higher that we'll have a vaccine before a very effective drug. I'm hoping that within 2021, it's not only when it will develop, there are also issues of distribution of vaccine, the supply chain of vaccine. I mean, even with the regular flu vaccines, sometimes there are supply chain distribution problems. But I would expect that a vaccine might be available in the United States in 2021, not within 2020. That's my best guess. Clearly, it's very difficult to estimate all these things. Huh?
Thank you.
Professor, would you be able to sort of give a quick summary? I assume you're familiar with the University of Washington's projections.
Yes, I am familiar. Yes, it's very different model.
Okay, could you put it in layman's speak? Like what can we learn from yours or take away from yours that's different, I guess?
Yes. So what we learned, I mean, the two models have converged, it's fair to say, but we have not changed that much. I think the University of Washington model has changed. For example, if you look at the peaks the two models propose are similar. Ours is still a bit later, but now we are only a week away. We used to be several weeks away. Now, in layman's terms, what I would like you to consider, and that all models, I think I heard him from, I knew the saying that several people talk about, namely all models are wrong, some are useful. I believe both models are useful, and I believe our model is calibrated in such a way that takes into account parameters like social distancing, like the level of testing, that can be adapted to a county, to a hospital, to a state. we are currently expanding the model to Europe as well. But at the moment, I would say the two models have a reasonably consistent story. They're not the same story, but they're reasonably consistent.
Doctor, this is Greg Ladke from the Connecticut Mirror. I'm sorry I didn't get the message about the change in time. Could you give a very brief summary of what the model shows for Connecticut again?
Yes. And you can take a look at, if you take a look at the website COVID-analytics.io, I repeat again, COVID-analytics, one word, .io, you will see exactly the predictions for Connecticut. So, so our estimate is that the peak would be end of April, 30th of April. For example, a difference with the University of Washington model, it predicts an earlier peak. We predict a later peak. And also, it used to be that the University of Washington model predicted number of deaths that are much sizably higher than ours. In recent days, they have updated the model to be much closer to what we predict. But you can find detailed predictions for the state of Connecticut as well as in other states in this website under predictions. There are many other things there, but this one is relevant to your question.
Thank you.
Dimitri, thank you so much. This is
a pleasure.
This is a very unique partnership, and we're enormously proud of the relationship we have with MIT. MIT's world-renowned resources are being channeled here in Connecticut and here at Hartford Healthcare to help develop products and services for this crisis that can be applied across the world. And what I'm really proud of is we're using this data that Professor Bertsimas described today to make important decisions each day. We're using it as we manage our personal protective equipment, as we make decisions about where and how we transition patients throughout the healthcare system, and about what treatment methodologies we apply to certain patients in specific sets of circumstances. So it's very critical to us in this data, in channeling the importance of this data in ways to make our response more planful as we look at the surge becomes very critical. So having access to world-class, world-renowned experts here to do this work in Connecticut is critical. And I'm also very pleased with the generosity of MIT that they have willingly and broadly shared their early work and these findings, both with the state of Connecticut and our team, as well as now much more broadly. And we made a commitment at Hartford Healthcare from the beginning of this process that we would be transparent, we would be accessible, and this is the type of work we're using to drive our response in this crisis. Thank you very much.